first Thalassemia workshop, where we try to showcase all the hematologists working in the peripheries, where we do the diagnosis and the management of hematological disorders. So we will start off with the introduction to the diagnosis of thalassemias, and I warmly welcome two eminent professors who have done a lot of work in thalassemia. Senior Professor Anuja Premawardana from the Faculty of Medicine, University of Kelaniya, and Professor Sachit Methananda, Chair Professor of Pediatrics at the Faculty of Medicine, Ragama, University of Kelaniya. A warm welcome to both of you. And let me start by introducing Dr. Swarna Gundreka from the District Hospital Matale, where she will be talking to us about the screening program. Over to you, Swarna.
Good evening. Welcome you all to Thalassemia workshop. I would like to thank Sri Lanka College of Hematologists for arranging this workshop and giving me this opportunity. My topic today is screening for thalassemia. To begin with, thalassemia is the commonest clinically significant single gene disorder in the world. In Sri Lanka, there are more than 2,000 thalassemia patients or significant hemoglobinopathies around the country who drains a significant proportion of national health budget for their management. It is estimated that around 2.2% of our population are carriers. Thalassemia is always linked with difficulties in providing optimal treatment, which is a burden on patients, their families, and National Health Service. The only cure for thalassemia is bone marrow transplantation, which is very risky and expensive. Therefore, suitable preventive strategies based on the type of the disease burden of the country or particular area, the carrier density, ethical considerations, and the resources must be carried out. Any thalassemia prevention program has four main components: public education, carrier screening, genetic counseling, and prenatal diagnosis. Prenatal diagnosis is followed by identification of affected pregnancies and termination of the pregnancy, which is not possible in our country. Therefore, the thalassemia prevention program of our country is aiming screening of premarital population, identification of carriers, and prevention of marriages between two carriers. For this, we use three pathways of carrier screening. The NCD unit of Ministry of Health is conducting a national thalassemia prevention program aiming to screen all the school population, the premarital population of the country. The target is to screen all school children before they leave the school and provide a thalassemia carrier identification card so that later they will be able to choose a partner according to their thalassemia carrier identification cards. We also do family screening. The immediate family members of the non-thalassemia carriers are screened to exclude the carrier states. We also do patient screening. Patients with hypochromic microcytic anemias and those who are incidentally found to have hypochromic microcytic red cell N disease are screened in our clinics to exclude thalassemia carrier state after excluding iron deficiency anemias. Thalassemia carriers have mild hyperchromic microcytic anemias. So this feature is utilized in primary thalassemia screening process to identify the risk groups for thalassemia carrier state. If we do full blood count, if their MCV and MCH are low, we select them for secondary screening. Of course, in population screening, we directly select all the hyperchromic microcytic red cell indices for secondary screening. But in family screening and patient screening process, we can treat them with iron if they are having iron deficiency, and then select for secondary screening. Those who are having normal full blood count findings are issued with the full blood count green card. The secondary thalassemia screening is done by hemoglobin analysis by HPLC or hemoglobin capillary electrophoresis. Beta thalassemia carriers have characteristically elevated hemoglobin A2 levels between 3.5 to 7%. We also can identify most of the common and significant variant hemoglobins like hemoglobin E, sickle hemoglobin, hemoglobin D, etc., by the presence of abnormal hemoglobin bands in HPLC or capillary electrophoresis. Both of these methods do not exclude alpha thalassemia carriers, but in comparison to beta thalassemia major, the clinical burden of alpha thalassemia is very low in our country. After the screening procedure, we issue thalassemia carrier identification cards. Full blood count green card is issued after performing a full blood count only if their full blood count is normal. HPLC green card is issued after confirming that these green card holders are not carriers by HPLC or hemoglobin capillary electrophoresis. HPLC green card is the safest in terms of thalassemia prevention. All the identified thalassemia carriers are issued with a pink card. The marriage between two pink card holders, there is a 25% chance of having a thalassemia major child. Therefore, we counsel all the green card holders and we advise them to select a HPLC green card holder as their partner. As we have done only full blood count in full blood count green card group, we advise those green card holders to get an HPLC done if they select a pink card holder or full blood count green card holder or untested partner for their marriage. So having said that, this is the thalassemia burden in the major thalassemia center in our country, Kurunegala. I served Kurunegala Thalassemia Center in the recent past. So up to 2020, there are nearly 700 patients registered. 700 homozygous beta thalassemia patients are registered in Kurunegala. Almost all of them are transfusion dependent. There are also nearly 350 E-beta patients. There is a very variable clinical phenotype in E-beta group. A proportion are transfusion dependent. The majority are behaving like thalassemia intermedia, and there is a proportion who are asymptomatic. We also have very low numbers of other rare ones, homozygous E, D betas, sickle betas, some alpha thalassemias. So in total, up to 2020, more than 1,163 patients have been registered in Kurunegala Thalassemia Center, and about 200 patients died of complications of thalassemia. So what have we done to reduce the disease burden in Kurunegala? This is 2018 statistics. We have done more than 27,000 population screenings and identified about 4% carriers from the sample. And we have done family and patient screening as well. Of course, this is a very very target group. All are immediate family members of THAL carriers or hyperchromic microcytic anemias after treating iron deficiency. So we have identified 25% thalassemia carriers from this group. So in total, we have screened more than 35,000 individuals in 2018 for thalassemia, and we have identified nearly 3,000 thalassemia carriers, which is about 8.3% in 2018. In total, so far, Kurunegala Thalassemia Center has screened about 300,000 individuals and identified about 30,000 thalassemia carriers. So have we, with that extensive carrier screening,
So it all depends on the kind of alpha thalassemia you are trying to prevent and what is prevalent in the community. So if you have alpha 0 thalassemia or the severe form of alpha thalassemia, widely prevalent in a country or a community, trying to prevent severe forms of alpha thalassemia like HbH disease or HB by hydrops fetalis is an absolutely important thing. Now, that's the kind of program which would be essential for Southeast Asian countries. Now, in Sri Lanka, thankfully, alpha 0 thalassemia, where 2 alpha genes on the same chromosome is missing, is quite uncommon. It's almost restricted to some more community people. Now, it's not widely prevalent even amongst the Muslim community. We really don't know why it is found only in some of them, because the total number of patients with alpha 0 thalassemia in this country, total number of patients is very, very few. And I saw the data from Swarna in Kurunegala, they have about 6 patients. I think the total number is whom people have seen must be about 20 to 30 so far. There was an elegant piece of work done by Dr. Sashikala Suresh when she was working in Kurunegala some years ago. That was the first major publication on this, which identified the genetic defect in this community. Now, that is, so if alpha 0 thalassemia is a problem, integrating alpha thalassemia to the screening program would have been essential. But in Sri Lanka, we don't really have that as a major issue. On the other hand, alpha screening would be necessary as the question is not for genetic testing as a prevention program, but alpha genetic testing may be necessary in some situations outside the prevention program, as is happening now when hematologists or clinicians come across situations where there is unresolved issues of hyperchromic microcytosis, which is not responding to iron or which is not due to beta thalassemia trait. So rather than subjecting to patients to unnecessary iron treatment, because it is clinically necessary, you can test them for alpha thalassemia. But in community, the other scenario where you need to test for alpha thalassemia is in community surveys. Now, when you do community surveys of community surveys of anemia, now in most of the early community surveys of anemia, there is a very high prevalence of iron deficiency anemia reported in Sri Lanka, ranging about 30 to 40%. Now, the moment alpha thalassemia was begun to be tested using PCR, which I'm sure you are aware that it's very difficult to test for alpha thalassemia because there are no simple laboratory tests. You had to do PCR. When that was started, the iron deficiency prevalence in the community suddenly went down from 30% to about 12%. And this is because single gene defects of alpha thalassemia can masquerade as hypochromic microcytosis with mild anemia, which would often be lumped as iron deficiency anemia. So in short, testing for alpha thalassemia using genetic testing is not recommended in this country widely, just because you can do the test. It would be necessary for in community surveys. You should do it when you have unresolved issues of hypochromic microcytosis. But when you're dealing with communities, sub-communities who have alpha-0 thalassemia, in their family counseling, you will probably have to do it. And now this might become a problem because of migrant workers. In Sri Lankans going and working in the Middle East and getting married to, let's say, Filipinos, who, Southeast Asians having alpha-0 thalassemia. And when it comes to them, then of course you can have a higher risk, alpha plus in a Sri Lankan and alpha-0 in a Southeast Asian. You might end up with HBH disease outside even the Moor community. So these are things which we have to bear in mind. Thank you.
Thank you, Professor Anuja Premawardana and Nityananda, for your expert opinions. I'm very sorry for the inconvenience caused in the middle of the presentation. This concludes the thalassemia screening part of the workshop. Thank you for patient listening.
Thank you, Swarna, for that very nice presentation on screening. Thank you, Anuja, and thank you, Sachit, for that very illustrious and very clear answers for our questions. Now let me introduce you Dr. Thanuji Somaratna, who will be talking about thalassemia intermedia. Over to Thanuji.
Good evening, everyone. Can you hear me?
Yes, Thanuji, go ahead.
I will be presenting the first case of the today's session. The case is of a hyper-hemolysis syndrome in a patient with thalassemia intermedia complicated by allo and autoantibodies. This child was presented to us 2 years ago at her age of 7 years and 10 months. She was presented with yellowish discoloration of eyes and abdominal distension. She also had the features of anemia and thalassemic phases and hepatosplenomegaly. Her investigations revealed severe hypochromic microcytic anemia, and blood pictures showed the features of hemoglobinopathy with underlying features of megaloblastic anemia. The DCT was negative and it excluded the immune hemolytic anemias. In our institution, we had the capillary hemoglobin electrophoresis facility. So we performed it and found she's having a very high hemoglobin F levels of 97.6% with normal hemoglobin A2 and a small amount of hemoglobin H of 0.6 and hemoglobin A was not detected. Then the diagnosis was made as homozygous beta-0 thalassemia. Because of her clinical presentation at later age, the clinical diagnosis was made as thalassemia intermedia. But the investigations revealed she did not have the hemoglobin H inclusion bodies, and ultrasound scan showed significant hepatosplenomegaly. Serum ferritin levels were normal. The blood group was phenotypically RR. She was managed as a thalassemic intermediate patient and given blood transfusion, and she was discharged from the hospital and awaited follow-up reviews. This was a primary screening. Both parents were with thalassemia traits, and her first sibling died at the age of 12 years with a query history of heart failure and query history of Thalassemia, but the family was not properly screened and not done any genetic counseling, actually not screened for the thalassemia. So after the admission from her first transfusion, she came to the hospital again after 20 days with a yellowish discoloration of eyes and a low-grade fever. At this presentation, interestingly, her hemoglobin was 3.5, which was much lower to the previous pre-transfusion hemoglobin of 5.4. During this admission, she was again managed with blood transfusions and discharged with a plan of review in 2 weeks, but she again came in 10 days' time with high-grade fever and yellowish discoloration of eyes. Again, this time we noted her hemoglobin was less than the previous pre-transfusion hemoglobin. Because of this presentation, we suspected hyper-hemolysis syndrome in this child. Her DAT was also negative and retic count was also low. It is again favor of hyper-hemolysis syndrome. And again, during this admission, she was given 1,685 cc of blood transfusion, but her post-transfusion hemoglobin was 4.7. She did not show a good hemoglobin increment with the blood transfusion. For further management, she was transferred to the Professorial Unit Pediatric in the hospital. There, she was found to have high retic count, high serum indirect bilirubin levels, and increased LDH levels. Interestingly, her blood picture shows red cell agglutinations, and density was positive with C3d positivity. It gives a diagnosis of cold type autoimmune hemolytic anemia, and her indirect forms was also weakly positive, and antibody screening was positive, but not detected any significant alloantibodies. But later again, she was done an antibody screening and identified anti-Big C antibody. In that case, she also had alloimmune or hemolytic anemia. So her full diagnosis, complete diagnosis was hyper-hemolysis syndrome and allo and autoimmune hemolytic anemia. So she was managed with IV immunoglobulins and oral steroids, and she was given phenotypically matched blood transfusions, and splenectomy was done. She was vaccinated 2 weeks before at Amhara before transferring her to Raga. A long-term management plan was made to minimize the transfusion exposure because of the hyper-hemolysis syndrome. Plan for on-demand transfusion or to keep her blood pre-transfusion hemoglobin levels in between 5 to 6, and to give extended phenotypically matched blood to minimize further alloimmunization. And plan to start iron chelation and other annual routine assessments were arranged. After 2 years, now she's 10 years old, she's clinically stable, but she needs regular transfusions at every 4 weeks time. She's coming with baseline hemoglobin or in between 5 to 6, sometimes less than 5. She's on oral, subcut, and IV iron chelation. She maintained her ferritin levels around 2000. Professor Sajid, I would like to direct my questions to you. I have questions as a general for thalassemia intermedia. What is the target of pre-transfusion hemoglobin and post-transfusion hemoglobin in children with thalassemia intermedia? And what is the place for splenectomy in children with thalassemia intermedia?
Before I answer this question, If we go back to that case, I think this child has presented quite late and was definitely having homozygous beta 0 thalassemia. However, was behaving like a non-transfusion dependent thalassemia. I prefer that term to thalassemia intermedia. So now, after we successfully managed this hyperhemolysis, probably I didn't see this child after he left Ragaman. So now it seems that this child is receiving 4-weekly transfusions. In that sense, I think currently the child has probably having transfusion-dependent thalassemia. So it's quite common for them to shift the phenotype from non-transfusion dependent to transfusion-dependent thalassemia. If a child is transfusion dependent, I think we probably have to put that child to the transfusion dependent thalassemia protocol and try to maintain the pre-transfusion hemoglobin above 9. It's probably not right for us to transfuse a child 4-weekly while transfusing 4-weekly to maintain a pre-transfusion hemoglobin around 5 to 6, so that we are neither treating the anemia as at the same time we are overloading. So if we try to transfuse that child to a post-transfusion of about 14 and try to maintain the pre-transfusion of about 9, I'm sure we'll be transfusing that child exactly the same amount of red blood cells that we are doing now while maintaining pre-transfusion at 5. So probably have to change the diagnosis to transfusion-dependent thalassemia and manage as a transfusion-dependent thalassemia child. So that's the case. But we see truly thalassemia intermedia patients who we are managing as non-transfusion dependent thalassemia. So the non-transfusion dependent thalassemia group that we have in Sri Lanka, a majority are hemoglobin E beta thalassemia patients. At the same time, we have children who are having homozygous beta thalassemia, but for some genetic mutations, maybe hereditary persistence of fetal hemoglobin, or maybe co-inherited alpha thalassemia, they will behave as non-transfusion dependent thalassemia. So it's important to find out clinically whether the behavior of a particular child is transfusion dependent or non-transfusion dependent before we decide on the treatment transfusion regime. For example, if a child with hemoglobin E beta thalassemia, genetically we can't differentiate whether this child is going to be a transfusion dependent or non-transfusion dependent thalassemia. Only way that we can check that is by carefully withholding transfusion for some time at the beginning and see whether the child is able to maintain a baseline hemoglobin around 7. So my practice, the thalassemia intermedia patients or non-transfusion dependent thalassemia patients, if they are maintaining a baseline hemoglobin around 6 to 7 without transfusion, I would be happy with that. So I would, if it is above 7, that is definitely not a problem. But in my practice, we sometimes goes even to less than 6. But we have to remember this is without transfusion. So we take the transfusion burden out if they are maintaining a stable non-hemoglobin around 7, which is reasonably enough. Indication to transfuse such a child. If the child is symptomatic, yes, we will be putting them on transfusions. If the child has any growth failure, if the height is affected, if the weight is affected, and if we cannot control it by optimizing nutrition, yes, we might consider putting them back on transfusions. Or if the child has a rapidly enlarging spleen, we will be transfusing them probably as a transfusion dependent. So the question is, thalassemia intermedia, what is the target pre and post transfusion hemoglobin? If a child is truly a thalassemia intermedia, that child should definitely receive blood at least less than probably, I would say 4 or 5 transfusions per year. If someone is receiving more than 6 transfusions per year, I wouldn't label that child as a thalassemia intermediate. That child should probably be labeled as a thalassemia major or transfusion dependent on transfusion regime, where you maintain a pre-transfusion hemoglobin above 9. But if the child is truly a thalassemia intermediate or non-transfusion dependent thalassemia, I would be happy with the pre-transfusion, or more or less, I would like to call it as a stable hemoglobin of 7. So it's not right for us to label a child as thalassemia intermediate and to transfuse monthly to maintain a pre-transfusion 7, which is happening quite often in this country. So we label as thalassemia intermediate, and we think that the pre-transfusion 7 is sufficient. However, that child is being transfused monthly, getting 12 transfusions per year, at least 8 to 10 transfusions per year, aiming for a post-transfusion of 11, and after 4 weeks coming back with a pre-transfusion of 7. There we are neither managing anemia nor iron overload. So the definite answer is to decide whether this is non-transfusion or transfusion dependent. If it is transfusion dependent, put them in the proper regime of pre-transfusion above 9. If they are maintaining a stable hemoglobin above 7, yes, can manage as non-transfusion dependent thalassemia. I hope that answers your question. What's the place of splenectomy? Splenectomy is not very often done nowadays globally for thalassemia. Definitely for thalassemia major, because of the successful transfusion regime, we don't see that degree of splenomegaly. Most of our children with thalassemia does not have hepatosplenomegaly because of the adequately transfused. So that's not generally indicated. But when a child has non-transfusion dependent thalassemia or thalassemia intermediate, where we would be keeping the child in a relative anemia, in a relative chronic anemia to prevent iron overload, these children will develop splenomegaly. So the definite indication for splenectomy for me is hypersplenism. If someone has developed hypersplenism and if the platelet count, white cell count is persistently low, then I would definitely consider splenectomy. Apart from that, we generally don't have a definite indications for splenectomy. Very large transfusion load may be considered, but it's again a relative indication. In the case that you discussed just now, so I think the questions are coming lower down, but I recollect sort of how difficult it was to manage that child. So the hyper-hemolysis syndrome, it's not a very clear entity. It's a combination of autoimmune hemolysis as well as destruction of transfused red blood cells. The most important thing for someone is to withhold transfusions and to be happy with a very low hemoglobin, because you have seen that child has been transfused 1,600 ml of blood and ultimately ending up lower hemoglobin than the pre-transfusion hemoglobin. Sorry about that. I hope you can hear me.
Yes, sir.
Yeah. And that was an indication. That's probably not the indication. That indication was not the thalassemia, but probably as a part of the management of autoimmune hemolytic anemia, we did splenectomy in that child. I hope I answered the 2 questions.
Okay, thank you, sir. Professor Sachit, I have also another set of questions regarding this particular child. I would
Yes.
like to know about the hyperhemolysis syndrome. So how common to see the hyperhemolysis syndrome in thalassemic children? And in this particular child, if the child needs a higher hemoglobin target, as elevation needed, as you said, so can she have a recurrence of hyperhemolysis syndrome? In that case, is there any place of rituximab in hyperhemolysis syndrome?
Answer to the first question, I have seen only 2 patients with hyperhemolysis syndrome probably after I returned. That's probably the last 7 years. So one was referred to me from Jaffna, and the other one is this patient who just presented. Both these patients were managed as thalassemia intermedia, and in fact, they were diagnosed at very later ages, around 7 years. So that's a classical presentation. So someone who starts transfusions quite late can develop hyperhemolysis for the first or second blood transfusions. So it's not that common. I don't think it's a very common entity. But however, you have to be very careful in starting transfusions if you diagnose transfusion dependent thalassemia or even thalassemia intermediate at a later age. If child needs a higher hemoglobin threshold in case of affected growth or iron overload, so I think for me, the differentiation is whether someone is able to maintain a stable hemoglobin above 7 without transfusions. If not, we would be thinking of a hemoglobin threshold of 9 and managing as transfusion-dependent thalassemia. It's quite common for some thalassemia intermediate as well as a large proportion of hemoglobin E thalassemia patients to maintain a stable hemoglobin around 6 to 7 without transfusion. So that's a good threshold for them, which if it is not affecting growth. The recurrence of hyperhemolysis syndrome, I don't know the answer. I doubt it quite a lot. I think if you have, as I see it now, you have been transfusing this child monthly, so probably unlikely. That's been described with the first few transfusions in an untransfused child. I would say probably unlikely, but to be honest, I don't know the exact question. Any place for rituximab? Yes, there is. So there are so many options. All options available for autoimmune hemolysis can be considered. So rituximab can be considered. But still, if this child develops another episode of hyperhemolysis, I would still go for prednisolone, maybe IVIG, and failing of which I would be going for rituximab. We have used rituximab not for hyperhemolysis or autoimmune hemolytic anemia, but in ITP we use it quite often. But here, yes, it can be used probably as the third line.
Thank you very much, Professor Sachit.
Next, we have Dr. Sevanthi Pasnayaka.
ඔය ගේම් දේවල් මගහැරෙන්න හොඳට නිදාගමු.
Dr. Sevanthi, you are muted.
Sorry for the interruption. So the topic given to me, good evening everyone. The topic given to me today was difficulties in managing iron overload. I have 3 cases in line with questions to both Professor Anoja and Professor Methananda. Yes, so the first one is Mrs. STL, a 25 years lady with sickle beta thalassemia. She was diagnosed at around the age of 9-10 with a hemoglobin S of 46%, fetal hemoglobin 9.8%, HbA2 4.5%. The blood group was ORHD positive. She was transfusion dependent since the age of 15 years with 6 to 8 weekly blood transfusions. And then she developed red cell alloantibodies, anti-C, big C and kid B by the age of 18. She did not have any sickling crisis. She had splenomegaly and iron overload, and her serum ferritin was maintained around 2,500 to 3,000 but she was on oral iron chelation, hydroxyurea, and penicillin prophylaxis. At the age of 22, her first pregnancy ended up in an early second trimester miscarriage with a life-threatening hemorrhage, where they found it very difficult to find cross-match blood, and she had a very narrow escape. Yes, then she presented to me with a positive pregnancy test as soon as I reported for duty in that station, and she was very keen to continue the pregnancy. I had to stop iron chelation and hydroxyurea, and we continued the penicillin prophylaxis, and aspirin was started. Transfusion frequency gradually increased to 3 to 4 weekly intervals, and blood we had to transport from the National Transfusion Center, Colombo. Her hemoglobin S was 30% at 20 weeks of gestation. Fetal growth was uneventful. There were no sickling complications.
Can you advance the slides, please?
She was referred at 32 weeks to Dicesa Maternity Hospital due to the preceding history and convenience of obtaining cross-match blood and the availability of red cell exchange transfusion, which we did not have in my station at that time. She delivered without any complications. There had been no red cell exchange needed. The baby was well, and
Sevanthi, can you advance the slides, please? Sevanthi? Share the screen, Sevanthi, and then just go down.
can you hear me?
Yes, we can hear you. Share the slides.
Sorry?
Share the slides.
Am I sharing it?
No, we can't see it. It is
It's
okay.
in my
before.
screen.
Yeah.
Wait, I'll share it again.
Okay. Okay, right. Thank you.
Is it okay now?
Now it's okay.
Yes. So she was delivered You can hear me as well.
Yes, we can.
Right.
Thank
So she remained transfusion dependent at the same interval, same dependency, 4 to 5 weeks intervals, postpartum as well. We recommenced the hydroxyurea. Serum ferritin was above 6,000 postpartum, and even during pregnancy, it was above 6,000. We started IV desferrioxamine 50 milligrams per kg as an overnight infusion with every transfusion. The desferrioxamine was then the deferricirox. We started 1,600 milligrams daily, but there was no significant response. The serum ferritin remained same 3 months postpartum. Then the IV desferrioxamine, we gave a 5 consecutive day infusion. Still, there was no significant improvement noticed. Unfortunately, I have left this place and I don't know how the patient is now. So my questions are to Professor Anuja. How to prevent iron overload in pregnancy when transfusion requirement increases and iron chelation has to be stopped? Is Professor in?
Thank you, Sevan. This is a bit unusual in one sense. Am I back? Can you hear me?
Yes, sir, you are back. We can hear you, Prof.
Yeah, okay. Unusual in the sense that you are talking about, before we talk about iron overload in pregnancy, which I think is what Dr. Zewandi is asking about. We are talking about a sickle beta-thal patient who is transfusion dependent now. That in itself is quite unusual, because you talk about patients with beta thalassemia or E-beta thalassemia and other forms of thalassemia intermedia. But I think one of the key issues about sickle cell disease is that use of blood transfusions is usually given for specific reasons, and usually you don't really consider somebody to be transfusion dependent. Even the homozygous sickle cell, they are not really classed as sickle blood transfusion dependent. You put them on transfusions for a specific reason. Well, this, I must confess, when we are talking about managing sickle cell, experience of managing sickle cell, I'm sure everyone's experience is much more than mine, because we see very few in this country anyway. I think the total number of patients in Sri Lanka is, when we published our last paper, all we found was about 60. So maybe the maximum number is about 100. So we are not talking of massive numbers, unlike in Africa. So, but overall, I think you don't speak of transfusion dependent sickle cell disease or sickle cell beta thalassemia. So I think that in itself, why that is so has to be examined. But the question here is not that, but I think what you are talking about is how do you manage Was it iron overload that you're talking about?
Yes, yes, iron overload.
Dr. Sevandi, you're
Was-
talking about how do you manage?
Iron overload,
Right.
how to
So I think
prevent it?
that
Like,
the best.
we can't give any iron chelation.
Yes. Now I think forget the sickle. Yeah, right. I think so. Let's take the sickle part out of the equation. Now let's talk about just iron overload management in thalassemia in pregnancy. I think the best answer to this is I think you should plan a pregnancy if possible for any patient with thalassemia, be it intermediate, which is the more common group of thalassemia patients, or what you usually call non-transfusion dependent thalassemia patients who are more likely to become pregnant. And increasingly, we are seeing individuals who have beta thalassemia major, few of them really. Like in our unit in Mahara, we have now about 6 patients who have born children. Now that's not a huge number, but it's something to celebrate from, what it used to be 15 years ago. So when you talk about managing iron overload in pregnancy, you should embark on the journey before the pregnancy by chelating them well in advance. Now, as anyone who works in the field would know, this is not an easy task at all, because we are living in the real world, not in the TIF guidelines. So we are having patients who are already iron overloaded, who haven't had received the drugs continuously for various reasons. And then sometimes pregnancy, of course, which is a blessing, but would come as a surprise for the clinicians. So in that context, management of iron overload, the constraints on us would be that Deficiencies cannot be used. Now, Deficiencies is contraindicated, but here again, I think it has to be mentioned that there have been no cases reported in literature, inadvertent use of Deficiencies in the first trimester with congenital abnormalities. There are no such reports, but you are not advised to continue Deficiencies once you know that you are pregnant, or if somebody wants to become pregnant, you are advised to stop it if that is practical. Now, desferrioxamine, on the other hand, again, you don't use it in the first trimester, can be used in the third trimester, but depending on the clinical circumstances, can be used in the second trimester as well. So now, if you have no major threat of organ damage, you cannot use chelators at all during the pregnancy. That would be the safest if you are dealing with not so high iron overload, and that it all depends on the measures of iron overload you have. I think the hematologists in the audience, of course, would be very well aware that you should not purely be based only on ferritin. If you have access to cardiac and liver MRI, and thankfully, at least we have one center which is doing that, which unfortunately is now overburdened with work, doing cardiac MRI and liver MRI. And so if you have access to that facility, it is best that your patients have that report prior to pregnancy. Now, based on this, if there is no major threat to life, you could not use chelators at all during pregnancy. But if there is significant iron overload, and if you are concerned about the the safety of the mother, you can use desferrioxamine in the 3rd trimester, and also if necessary in the 2nd trimester, but it is strongly advised not to use deferrosirox. Now then comes the lactation, provided there is no issues. Again, desferrioxamine can be used. Deferrosirox is best not used. Again, I think you have to take into considerations the overall clinical picture. Sometimes you might have to compromise on the lactation period and to go on a pretty aggressive chelation for the mother if she has accumulated a lot of iron. So in summary, iron overload is best avoided prior to pregnancy, but as we know, it is not always possible. So you can use chelators. Desferrioxamine is preferred. And the doses, of course, as you know, would be 20, 30, or 40 milligrams per kilogram per day, depending on the level of iron overload. And if it is very high, you can go for 24-hour infusions. Thank you.
Yes, I think you have answered most of my questions in one go. How to get rid of iron overload during postpartum period, and how quickly and aggressively should you do it, is my last question to you for this case.
I think that is, again, I think I've already answered that all. It depends on the amount of iron accumulated and the threat to organs, threat to the heart. So it all depends. I think we should move away from just measuring ferritin alone. Ideally, we should have, that we can measure T2 star, cardiac. We should be measuring it every year after about the age of about 8 years. And but then the limitation, of course, as you all know, is the fact that the facility is only available at the Lady Ridgeway, which is now overrun with work. And R2 or Ferriscan is now available commercially, which we have only been able to establish for the liver. But we should be moving with the times once the financial issues are sorted, and get this technology to at least 1 or 2 other hospitals from other parts of this country, so that our patients have access to the technology, because there are radiologists and all you need is an MRI. It's the technique, the training which is necessary to do this. Any machine won't do. It's more than the machine, is the training of the staff which is necessary to do this. So if you have reliable data on cardiac MRI, and then with that and liver MRI. Liver, as you know, liver MRI is a good measure of body iron overload, which is not necessarily identical to threat to life from cardiac disease. Heart failure risk can be directly measured from T2 star of the heart. And if you have these 2 data together with other clinical data like echocardiogram, which is only useful if there is failure really, and your clinical wisdom, this will help you to decide on a better course of action. Thank you.
Thank you. So let's move on to the second case. more or less similar, managed at the same station. Mrs. LSD, 23 years, again a sickle beta thalassemia. HbS was 69.3%. HbA.
Move the slides, please.
I have moved it. I'll stop sharing and restart again.
Okay. Thank you.
So this is again a 23-year-old lady with sickle beta thalassemia, HbS 69.3%, HbA2 4.1%, and HbS 14.6%. The blood group was BRHD positive. She was non-transfusion dependent, but had about more than 20 blood transfusions by the age of 23. She developed red cell alloantibodies to anti-small c and big C by the age of 18. She has had mild intermittent painful sickling crisis with no ICU admissions, no splenomegaly and iron overload. Serum ferritin was less than 500. She was on hydroxyurea and penicillin prophylaxis. She has had two pregnancies. First two pregnancies were uneventful, normal vaginal deliveries. Yes. So she presented with a positive pregnancy test. We had to stop the hydroxyurea and we started aspirin. Penicillin was continued. The transfusion frequency increased, but was not transfusion dependent. About 5 to 6 units had to be transfused throughout her pregnancy. Again, the blood has to be transported from the National Transfusion Center, Colombo. The hemoglobin S level at 28 weeks and 36 weeks was 45% with no sickling complications. We performed the red cell exchange at 36 weeks before the delivery. And we also had the facility at that time in our hospital. And we could reduce the HbS level to 26%. A well baby was delivered at 37 weeks who was later diagnosed beta thalassemia trait. Mother was not iron overloaded. The transfusion frequency returned to the pre-pregnancy pattern. So that was this case. And my question again to you, Prof. Anuja, how do you explain the difference in the behavior of these conditions, of the disease condition of these two patients? They're not related.
Thank you, Dr. Again, two patients with sickle beta thalassemia, and both pregnant patients, very different. And I think the issue was behavior in pregnancy, and even before pregnancy has been different in the first one, I think.
Entirely
so,
different.
Yes, so this is, I think, somebody, as I mentioned before, the first patient has to be really checked carefully, because the reason why I'm saying this is had an experience with someone like that who has been classed as transfusion dependent, and we were actually able to stop transfusions in that patient because as you know, in the same thing which I did mention before, the reason why people get transfusions, whether it is a subjective or an objective thing, you have to very carefully assess this. Without actually knowing the patient, I would not be able to make any judgment. But just the word of caution is that, you know, this transfusion dependency before pregnancy, in the absence of alloantibodies, autoantibodies and all that, is very, very unusual. But leaving that aside, why patients with a single gene disorder is clinically different is very well known. Like, this is the same thing that we know about E-beta thalassemia or HBH disease. Nominally they are the same. So you call them S-beta thalassemia in this case, or hemoglobin E-beta thalassemia. Nominally it's the same person. It's like calling, why should all De Silvas not be the same? The name is De Silva, but De Silvas are not all the same, or Bandaras are not the same. So, the reason is because it could be genetic or environmental. When you talk of the genetic factors which contribute to the variability of sickle cell disease, the first thing you talk about is the haplotype. Which haplotype does the sickle cell gene sit in? So if your sickle patient is African sickle as opposed to Indo-Arabic sickle, I'm sure everybody in the audience is aware of this. There are two main kinds of sickle that you talk about. Sickle is thought to have originated at least 5 times independently, 4 times in Africa and once in the Indo-Arabic region. So as the Bantu, Cameroon, Senegal, and Benin, which is in Africa, and the Indo-Arabic is the other origin. So the African sickle is known to be very harsh, and that's absolutely true, whereas the Indo-Arabic sickle is relatively mild. But even within Indo-Arabic, there is enormous phenotypic variability. Now, we did not originally know the kind of sickle we had in Sri Lanka until very recently, when we were able to show that almost 95% of our Sri Lankan patients have the Indo-Arabic haplotype. And there were about 3 or 4 out of the 60 patients haplotype who actually had the African haplotype. So if you happen to have the African haplotype, you could explain a phenotypic variability. But that doesn't again mean they will be transfusion dependent. The variability would be they will have more crisis. They will have more sickling crisis rather than, remember, sickle is not a disease which requires blood transfusions. Transfusions are given by doctors to prevent either strokes or other complications. And it's usually physician initiated rather than, unlike in thalassemia, where, lack of transfusions will actually kill you. So first thing is the haplotype, and then even in the same haplotype, for example, Indo-Arabic haplotype, if you have a mild beta mutation, you will have a mild disease. If you have a severe beta mutation, you have a severe disease. But this is definitely not applicable in Sri Lanka because all the beta mutations in the Sri Lankan patients are severe beta mutations. So this doesn't really apply. We know for a fact that there are no mild beta mutations in Sri Lanka. Then the other factors which contribute to genetic mildness is co-inheritance of alpha thalassemia. So if you have alpha thalassemia and beta thalassemia together, you all know that it ameliorates the disease severity. And other factors which upregulates HbF, whether you have XMN polymorphism or BCL11A or another polymorphism which upregulates F, you know that if you have F, it reduces the severity of sickle, and that's exactly why the Indo-Arabic haplotype is milder, and because the Indo-Arabics have higher F compared to the Africans. So all these are the genetic mechanisms which you should look at if your person has a milder haplotype. The other, of course, is the blood. If you have developed alloantibodies, autoantibody, you will require nothing to do with the haplotype. If you have been, remember, in pregnancy, sicklers who have never been transfused, there's a higher risk of developing transfusion And this is another thing which must be stressed. Pregnancy in sickle does not require blood transfusion. So even a homozygous sickle cell, we have about 12 homozygous sickle in this country. In the last survey we did, we identified them. Just because you are SS, it does not mean that you need transfusions in pregnancy. Transfusions can be managed without transfusion unless there is severe anemia. The reason, of course, is that sickle is a very low affinity hemoglobin, so it tends to donate oxygen. So blood transfusion is not essential. So it all has to be taken into consideration. Just because you have a homozygous sickle, it does not mean that you need to, you should be transfused. So these are factors to be considered. Recap, why should a sickle beta thal be different from the other? The haplotype, the beta gene, alpha genes, upregulating F, whether you have it or not. And then, of course, other factors like coexisting illnesses, which you have to think about, and transfusion complications. But don't forget the patient perspectives. Some patients behave in a certain way. This is the thing that I am trying to stress, seriously talk to the patient to see, I really can't pass judgment here without actually seeing this patient, whether this is a subjective transfusion dependence or not, because there are ETAL patients who are just like that as well. Right, thank you.
Thank you, Professor Anuja. Case 3. It's a child, 2 years old, diagnosed beta thalassemia major, presented at the age of 5 months. 5 months in June 2020 with severe anemia. The hemoglobin at diagnosis was 4.1 and the serum ferritin has been 290. And the HPLC, HbA 8.5%, A2 3.8%, and F 83.7%. I'm not very sure whether this is a post-transfusion blood sample that was sent to HPLC because I was not the person who was there when the diagnosis was made. Both parents were beta thalassemia trait. So he has completed 10 units of blood transfusion in 4 months of diagnosis, but the ferritin has been less than 1,000 at that time. The ferritin reached above 1,000 in January 2021 and went up to 2,500, where the treating team has started IV desferrioxamine 20 milligrams per kg per month. That means per transfusion, not with each unit of blood. Per one transfusion, they have given 20 milligrams per kg, which was continued monthly until the child was referred to me in October 2021, where the serum ferritin was 3,525. Then actually I had a chat with Prof. Sachit, and we were planning, while we were getting down an infusion pump and all, I gave IV desferrioxamine 50 milligrams per kg infusion with that transfusion. And in another 2 months, the hemoglobin, the serum ferritin has gone up. By that time, the mother has got an infusion pump where we started subcut ion chelation desferrioxamine 40 milligrams per kg 3 times per week. And before that, the previous month, because the ferritin was very high, with after consulting Professor Sachit, we started oral deferasirox, minimum possible dose, that was 400 milligrams daily. We checked the liver and renal function after about 2 weeks, and then after a month, which was normal. The child was tolerating it. So I continued. I thought of continuing it up to about 3 months and check how he fares. The ferritin was 3,300 in January, because the mother has been doing the serum ferritin every month since then because it was high. So he is now on subcut infusion and oral desferrioxamine. We are awaiting a ferritin next month, next visit actually this month. Again, regarding his hemoglobin, the pre-transfusion hemoglobin was always around 6, where we have transfused him to get a near normal hemoglobin every time. But within a month, it drops to 6 when he comes for his next clinic visit. So this time, actually, this day was before his second birthday. So mother has got just 1 unit and has gone home on that day. The hemoglobin has been 5.9 and they haven't checked the post-transfusion hemoglobin as well. So we are waiting to see him again this month. So my questions are for Professor Sachit Mettanand. What is the reason for the very early, less than 6 months presentation of beta thalassemia major?
As Prof. Anuja rightly pointed out, so the variability in thalassemia is enormous, even among the transfusion-dependent ones. And it's not very rare for us to see children presenting less than 6 months. In fact, the old patients we saw during the last 1 or 2 years, they present quite early. So some babies present around 2 months, 3 months, even 4 months. The reason probably is that they are being picked up quite early. So there are being the new sort of a follow-up well baby clinics and the midwives visits and everything. There's someone who picked the spleen, someone might sort of found that they are failing to thrive. So they are being picked up quite early and then they are being investigated, and generally most children now present well before 6 months. So around 4, 5 months or even 2 to 3 months is quite common. I think that's probably the improvement in the pediatric care as well as the field visits of the field staff. That's probably is contributing, because we know since birth the hemoglobin A will, in a normal individual, the hemoglobin A will be shifting to hemoglobin F, and that happens around 3 months of age. So it's not after 6 months they generally present less than 6 months. They will start developing anemia from 2 months onwards. And earlier probably people did not pick that quite early.
What is the reason for the drop in the pre-transfusion hemoglobin, though we have topped up adequately in the previous transfusion?
My practice was to aim for a post-transfusion of 14. We are not aiming for a post-transfusion 12.5. You correctly said you have topped up to a near normal level. But what we need to make sure is that their mean hemoglobin is 12 to 12.5. So that means during the 1 month after the transfusion and before the transfusion. So otherwise, we will probably not suppressing the extramedullary hematopoiesis as well as bone marrow expansion adequately. I would probably, we generally do calculations and transfuse rather than giving blood, but that's perfectly okay, whatever the way you do, but probably we should aim at a higher hemoglobin, that is 14, I guess. The reason for the drop in pre-transfusion hemoglobin, we also see, so our patients, we generally don't get as low as 6 pre-transfusion. Most of the time they will come above 9. It is not that hard. Sometimes they come around 8, 8.5. The few reasons that we think this rapid drop, one thing we are not entirely sure about the freshness of the blood. So we know the blood is something that has a half-life, red blood cells, and majority maybe the most of the red blood cells that you transfuse are dead by that time, or they will survive for about 1 or 2 weeks. So that is one reason. Second thing, we don't exactly know the hematocrit of the blood in our blood banks. So the calculations that we make, that is pre-transfusion, so 14 minus pre-transfusion into 4 into body weight, is based on if you are doing it based on a calculation, I don't know whether you do it, is presuming a hematocrit of 75 in the packed red blood cells that we receive from the blood bank. We recently did the small ward test because we have a hemocytometers in the ward to be used for dengue patients. And when we check the hematocrit, it's around 60%. There's nothing wrong with the blood bank. So different blood banks maintain different hematocrit. So we have the blood bank hematocrit is about 60%. So although we are transfusing large volumes, we may not be transfusing the packed red cell mass adequately. So those are the possible reasons that I think. But I would probably target a slightly higher post-transfusion hemoglobin. Because
Yes, actually,
overall, worldwide, it's accepted if you are managing as transfusion-dependent thalassemia, we need to maintain the pre-transfusion above 9.
The calculation was made to a post-transfusion hemoglobin of target hemoglobin of 12 from the pediatric ward. I must advise them to make it 14 next time. Is this degree of iron overload expected?
Obviously, that's a huge problem for us. One thing we as pediatricians, at least I prefer not to put them on subcut or in sort of a subcut. So iron chelation. We try our best to, I try my best to manage them only on oral iron chelation. And the other thing, IV iron chelation is also not very practical. I mean, we generally tend to send them on the same day, so that they come for the transfusion and they go home. Most of the time they come on Saturdays or Sundays. So the quality of life is maintained. So that's one aim that we are doing. So is this degree of iron overload expected? Yes. We recently did, not recently, about 3-4 years ago, we evaluated the trends of iron overload. In fact, most of our patients had serum ferritin above 1000 even before they get the 10th transfusion. So as in your case, they have it has happened after the 10th transfusion, but surprisingly, this child has received 10 transfusions within 4 months. So this degree of iron overload is expected. Yes. Even when they are around 1 year, I see sometimes serum ferritin above 1000, and if you don't do anything, it goes up to 2000, 3000, and 4000, even above that very rapidly. And what we saw is in the first few years, first 2-3 years, the increase in iron overload, increase in serum ferritin is very rapid for some reason.
So what are the deficiencies in our regime of transfusion and iron chelation, and advice regarding the future management of this patient with regard to transfusion support and iron chelation, please?
Yeah, I'm not very advocate of IV iron chelation. I don't think giving once a month or with the transfusion is not going to, I don't think it will help, because we all know desferrioxamine will act while it being transfused, either subcut or intravenous. So we are probably giving 1/30th of the required dose if we are giving iron chelation only during a transfusion. That's number one. Number two, the oral iron chelator, Deficiencies, although it is recommended after 2 years, we very often start it before. Most of the unit, because we will have to start iron chelation before 2 years in all our patients with thalassemia. They will be iron overloaded otherwise. So we also use that practice to start subcut IV desferrioxamine and then convert to deferresirox at 2 years, which I think is not really necessary. Although we don't have data on deferresirox, published data before 2 years, there's no big harm in using deferresirox. So all our patients, we start with deferresirox, even if they are 1 year 3 months, 1 year 4 months. And that's probably, it's not based on the scientific evidence. There is no evidence because that has not been tested. However, in theory, there's no reason why a child less than 2 years behave differently to a child more than 2 years. So our first line iron chelator is oral iron chelator, Deficiencies. Starting dose is between 20 to 40 milligrams per kg per day. And it's quite widely available. We don't know the quality of the drug that's available at the moment, but it's working to a certain extent. So I would rather start Deficiencies quite early rather than waiting for the subcutaneous pump. And when to start it? We again start a bit early. We don't wait until the ferritin goes beyond 1,000. We don't wait until they are given 10 transfusions. We tend to start around 6 to 8 transfusions, which is again probably will come into the guidelines quite soon. So 6 to 8 transfusions, and when the ferritin is about 800, we would be starting. And if the serum ferritin, if we are unable to manage serum ferritin with Deficiencies highest dose, sometimes when the child grows older, more than 2 years, although the recommended highest dose is 40 per kg, we tend to give slightly higher doses even, maybe 50 milligrams per kg. These are out of the guidelines, but still we use that. And in that, if failing of which, we have to go for the combination regime, which we try to avoid, because the advantage of having oral iron chelator is lost in children. Once you put them on a subcutaneous infusion, then the quality of life will drastically go down. But in certain instances where we are not able to manage iron overload or serum ferritin with only the Deficiencies, we will be putting them. I would probably give it at least 5 to 7 days a week rather than 3 days a week. Maximum iron chelation possible to bring the down serum ferritin as soon as possible. So I would give the highest possible dose of Deficiencies, 40 milligrams per kg per day, and probably with the serum ferritin of about 4,500, I would be giving 40 to 50 milligrams of desferrioxamine subcutaneous infusion all 7 days a week if they are quite compliant. So, and even with that, you may not be able to achieve the optimal control, but we have done our best. So that's the best that we can offer.
Right. Thank you very much, Professor Chitmethananda. This concludes my presentation today. And I thank Sri Lanka College of Hematologists for giving me the opportunity, and Professor Anuja and Prof. Methananda for giving us valuable advices and opinions. Thank you for your patient listening.
Thank you, Sevandi.
Thank you, Sevandi. Over to Dr. Sonali Gunathilaka to continue with the presentation on cardiac complications in thalassemia.
Can you all hear me? Can you all hear me?
Yes, Sonali, we can hear you.
Good evening. Thank you for joining the thalassemia workshop. My topic today is causes for cardiac complications in thalassemia major patients. First, I will discuss this case. It's Mr. K, 30-year-old patient who presented with facial and ankle edema for 1 week's duration, and he had mild shortness of breath. He was diagnosed at the age of 1 year, and since then he has been on monthly regular blood transfusions and iron chelation with desferrioxamine and Deficiencies. The investigations reveal a very high serum ferritin. It has been around between 6 to 7,000. And even last year, it has gone up even to just more than 9,000. And in January, we did another serum ferritin. It was 6,913 because the chelation doses were increased during the last year. And echo from 2015 to 2019, it was normal. In 2020, the ejection fraction was 60%. In 2022, the February, the echo showed moderate left ventricular dysfunction, moderate TR, and impaired right ventricular systolic function, pulmonary hypertension. And at that point, the ejection fraction was 45%. So when you talk about the cardiac morbidities associated with thalassemia major, there are several causes for it. One is the chronic anemia. So as you know, the body mechanisms are there to maintain the adequate oxygenation into the tissue. This increases the heart rate and increased dimensions of the heart, that means cardiomegaly, and it increases the heart stroke volume. The chronically anemic patients have a higher resting O2 consumption. So this leads to high metabolic demand and higher stress on the heart.
Dr. Sonali, excuse me, can you please move the slides?
Yes, I'm moving, madam. Can you see the second slide?
Only the first slide is there. And make it full screen, slideshow.
Can you see the full screen now?
Can you make it enable editing?
One second. Right, can you see? Can you see the screen now?
Yeah, we can see, but only the first slide there.
Can you see it now?
Yes, Sonali.
Right, so we know, right, second slide.
Move
right.
the slide, Sonali.
Right.
When you
Now, this is a second slide. Can you see it, madam?
no.
I can see the second slide. Iron overload related to related cardiomyopathy.
It is still on the first slide.
What's happening? Can you see it, madam?
Yes, we can see it now. You may proceed, Sonali.
Right. Iron overload. Now, this is the main. This is a very important reason for cardiac problems in thalassemias. The normal heart intakes iron through a transferrin receptor bound process, and this is highly regulated. So therefore, there's no iron load in a normal person. But in thalassemia major patients, there's a high iron levels in blood, and this levels exceeds transferrin binding capacity. then the circulating non-transferring bound ion fraction is increased. And these are oxidatively very active, and they enter the cells through other pathways. Other pathways means the non-specific, poorly regulated cation channels. And initially, this non-transferring bound ion is bound to cytosolic ferritin, and it is taken up by the lysozyme. And this is a protective method that the cell is having. It's like a buffering effect. But later, this doesn't work any further when the iron content increases. So then the heart muscle gets overloaded. Then increased iron in the cardiac cell causes disruption of the calcium, potassium, and the sodium channels. So this leads to arrhythmias, conduction and repolarization defects, diastolic and systolic dysfunction. And iron can also cause fibrosis and trigger apoptosis. Then pulmonary hypertension is another cause for cardiac complications in thalassemia major patients. What happens is that increased cardiac output and the diastolic dysfunction causes an abnormal loading of the pulmonary artery. And the phosphatidylserine expressing hematologic debris causes vasoconstriction and interval proliferation. If the patient is having lung disease, this also may cause vasoconstriction because of hypoxia. In thalassemia, patients have impaired endothelial relaxation, intimal proliferation and thickening, and abnormal vascular stiffening and degeneration of the elastic arteries. Some of the thalassemia major patients undergo splenectomy, and this spleen is the organ which removes certain cell debris. Some of these have vasoconstriction effects. Those are the phosphatidylserine positive platelets, platelet fragments, and red cell fragments. And these inhibit nitric oxide, which is a vasodilator and causes vasoconstriction. And spleen also removes brittle senescent red cells and suppresses intravascular hemolysis. And if the spleen is not there, the hemoglobin that is released is a powerful oxidant, and it scavenges nitric oxide, as I said earlier, which is a vasodilatator. Splenectomy also leads to thrombosis and pulmonary hypertension. Iron overload, when it occurs in the endocrine glands, which support the heart, it again affects the function of the heart. So if the patient is having diabetes due to problems in the pancreas, it causes hyperglycemia, and this is an oxidative stress on the heart, and it worsens the effect of iron overload. Low insulin levels can be a problem because it causes energy utilization in the heart. Deficiencies in growth hormone also impair cardiac function. Dysfunction of thyroid and parathyroid glands impair metabolism and regulation of calcium. Then there are many nutritional deficiencies associated with thalassemia major. Thalassemia is a hypermetabolic state and a chronic metabolic causes chronic metabolic stress to the heart. So there are some nutritional deficiencies, vitamin and micronutrients deficiencies, which may not directly but indirectly cause problems for the heart. As the thiamine and riboflavin deficiency can cause cardiac and endothelial dysfunction. So the cardiac complications, conduction and repolarization defects, arrhythmias, diastolic and systolic dysfunction, cardiomegaly, pulmonary hypertension, and heart failure. So we can diagnose it by X-ray, ECG, and echo and MRI scans. So though there are so many causes for cardiac morbidities in thalassemia major patients, it's the iron overload is the main cause for cardiac problems in these patients. So there are questions to be asked from you, Professor Anuja. What is the best iron chelator or combination for patients with cardiac complications?
Okay, I think that was a very, very good review, Dr. Sonali, about the heart in thalassemia. So just to put things in perspective, I think there's another thing which, or if there are any postgraduates, I think they should remember is that the heart disease in thalassemia, when it comes to thalassemia major, it is predominantly due to mainly heart failure, mainly due to iron overload related complications, whereas on the other hand, for non-transfusion dependent thalassemia, and when I say non-transfusion dependent thalassemia, you have to be very careful what I mean by that. This is not non-transfusion dependent thalassemia who have been treated as transfusion dependent thalassemia. You know, that word is being heavily abused. So these are non-transfusion dependent thalassemia who are not actually on transfusion. Their main cardiac disease is pulmonary hypertension. So that's one of the major differences which has to be appreciated. So the question is, how do you treat heart disease in thalassemia patients if it is due to iron overload? I think the first thing to appreciate is that it should be prevented rather than letting it become a festered wound. Now, even in Sri Lanka, if you manage patients well, and taking all the other factors also, thankfully, patients with severe heart failure, the cause of death of thalassemia major due to heart failure is actually now reducing. Heart failure continues to be the leading cause of death in thalassemia major, whereas in a very recently conducted survey in Kurunegala, Dr. Dayananda Bandara's unit, in E beta thalassemia patients, the commonest cause of death is no longer heart failure due to iron overload, but it is due to infections. So infections is the commonest cause of death now and not actually heart failure. Definitely in E beta thalassemia, but in most centers, and I can vouch for the fact, it is so in Mahara unit, where actually heart failure is now going down. So good treatment with a very heavy contribution from the patient and the family can prevent this. I think that is the best message, and prevention is certainly better than attempting to cure this. Now, it was fascinating to listen to Sachit approach to chelation, and I completely agree with him, like, how much we violate the guidelines when it comes to chelation. The guidelines stipulate minimum age of chelation, and Sachit blatantly violates that by starting Deficiencies at a younger age. And we violate the highest therapeutic dose of Deficiencies. And I'm glad to hear that Sachit is doing that too. Highest Deficiencies dose is 40 milligrams per kilogram per day. And we are exceeding that as well. We are going up to 50, and it seems that Sachit is doing that too in the pediatric population. But that's not what I want to talk about. But essentially, what is the best chelator to use Now, that's a very debatable thing. So when you talk of heart disease, you talk of patients in the most extreme scenario where there is heart failure, where ejection fraction is reduced. I think like the patient that Dr. Sonali was describing, a patient who is knocking on death's door. And for those patients, I think there's no doubt that the best treatment is continuous IV desferrioxamine. IV desferrioxamine as a standalone agent given non-stop until the ejection fraction reduces is the best treatment. And there is clear evidence that that alone is effective. And combining that with defiraprone, which may be of advantage. Now, even in the absence of defiraprone, if you use IV desferrioxamine, if you catch them early, you may be successful in saving patients. Thankfully, my experience in treating that kind of patients is just 3. 2 of them recovered. Sadly, just yesterday, we lost one patient, a patient who we got from a different unit, who had identical data to what Dr. Sonali said. He had ferritins over 5,000, the last 6 values. And one of the big problems in dealing with adolescent and adult patients is, of course, loss of compliance due to other issues like having to keep the job, and priorities change and they are no longer under the control of parents anymore, like in childhood. So priorities become different, and his ferritin was never coming down, and he presented in failure and lasted just 3 days, the last 2 days in the ICU, but never really recovered. But the previous 2 occasions, which was actually almost 10 years ago, both we were managed to save with IV desferrioxamine alone. There was no defiraprone available. I have very little experience in using defiraprone, and this was even before we had deferasirox. And but unfortunately, both of them subsequently did not survive because once they left the unit, after about almost 3 months in hospital, compliance deteriorated, and about 6 months later, both of them died. So the good news is that we don't see a lot of patients in this scenario, at least where I work. So how do you treat? That is what you do, IV desferrioxamine. Remember, just like Sachit said, desferrioxamine does not work, or any chelator does not work by ad hoc usage. You have to use it continuously, and desferrioxamine half-life is just 30 minutes. So basically what we reinforce is that if you take the needle out, it stops working. So you have to give it the duration of usage. The duration rather than the number of vials is far more important. For people who have the ejection fraction is normal, but who have high iron overload, this is basically based on guidelines where you have easy access to T2 star. The T2 star level more than 20 milliseconds is considered normal. Between 10 and 20 is where you start heavy iron overload. Less than 10 is when you actually start seeing failure. You could see failure. So where you have in between levels between 10 and 20, there is place for using monotherapy of any of the drugs or using combination. And this is where the role of combination of desferrioxamine and defiraprone had been promoted. But there is contradictory evidence. how useful, whether you can use just one alone or both. But I don't think you need to get into controversies here. Use whatever agent you have in the highest possible dose. And if you don't think it's working, go for combination. Unlike in the pediatric population, this is the most important thing that I must stress. In adult populations with thalassemia major, we don't have the luxury of waiting. So we often combine. Now, we used combination therapy even before trials were available. So we have been using combination therapy in our experience. And partly because we don't trust the drugs we have. And so monotherapy, and the other thing is in the adults, because of the body weight, it is impossible to give, for example, desferrioxamine, the optimal dose. If you are going to give 40 milligrams per kilogram per day, you can't give the necessary vials. It's impossible. It comes to about 150, 200 vials. You just can't do that. So you obviously have to combine. So you would give deferasirox, maximum possible dose, 40 milligrams per kilogram per day, plus desferrioxamine, maximum possible dose. Now this is where I agree with Sachit. We actually go the opposite way. We don't start with the lowest possible and go escalate. We actually de-escalate. We start with the highest possible dose. If we see that somebody's life is at threat, we start with the highest possible dose, with, let's say, 40 milligrams per kilogram per day of deferasirox, and the highest possible tolerable dose of desferrioxamine. And this is a very, 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 very difficult task of convincing people to take desferrioxamine for long durations of time. But the maximum tolerable dose, number of vials would be about 3 vials a day, usually 4 vials a day. Very often causes a lot of irritation in the skin. For, if possible, 7 days. Hardly anybody takes it for 7 days. And we would convince them to take it. So coming back to the short answer, if what is the best drug? What is in guidelines and what we have here, you have to be very practical in what we use. Basically, what you have to realize is that even in heart failure, if you catch them early, if you use IV desferrioxamine continuously, for a very, very long period of time, you can actually save them. Has it worked? Yes, it has worked. But does it work all the time? No, obviously not all the time. But if you have the luxury of combination therapy, by all means use it. Which combination is best? There is no evidence of superiority of one over the other. I must stress that. There's no evidence of superiority of desferrioxamine plus deferasirox over desferrioxamine plus deferiprone. So use whatever combination you have. And I'm sure everybody is aware that deferiprone is not widely available in this country. I hope that answers that.
Yes, sir. Now, my second question is a practical problem. How to improve the compliance of the patients who has poor compliance? Because this is a long-standing disease, and I have seen most of the patients are not compliant with this iron chelation.
It is actually a very, it's a bargaining thing. It all depends on the effort that the team puts in. The reason for poor compliance would vary according to the drug, the patient, and the social circumstances. I think I would not, I'm not comfortable nor experienced in talking about children, but in adolescent age group, which I begin to treat, compliance begin to be a major problem. And not only for the the subcutaneous desferrioxamine, but even surprisingly for Deficiencies. Now, Deficiencies was basically a miracle drug, from the parenteral to the oral. This would have been the perfect lifesaver because it was just once a day, dissolve in water and take it. But it's not as promising as it should be because there are lots of compliance issues with that. Because taking it early in the morning on an empty stomach is not very pleasant to a lot of children who go to school, let's say who have to travel from Varakapula to Colombo early morning in a school van and get up at 4 o'clock and take Deficiencies as the first thing, even before the cup of tea. They don't actually do that. So it's a difficult thing to do. And so it's just like the thyroxine tablet. When you don't take thyroxine in the morning, you forget to take. Some people opt not to take it at all, which is the wrong thing to do. So you have to be practical in scenarios like that. So take it at some time of the day. So taking it after meals, after dinner, and there is actually, we are doing a study about using Deficiencies after dinner. It's not really, data is not out yet. We are just collecting information. It's all started because people were not taking the drug in the morning, mainly adolescent children, and the ferritin level started to go down drastically once the drug was started to be used at dinner time. Now, that is one thing. Whether this is obviously not official data yet. This is just a practical experience started by one of our medical officers. So we'll see whether it is just increasing compliance or whether it actually increases absorption or whether it affects the pharmacodynamics. We don't know. Number two, I'm sure you are aware that the pharmaceutical companies have changed the preparations from the Deficiencies tablet from being a tablet to from a dissolvable tablet, a dispersible tablet, to a tablet where you actually swallow it. And by doing that, it increases absorption and reduces the gastrointestinal irritation. So these are methods that have been tried out by the pharmaceutical company itself, but this of course is not available in Sri Lanka. So this is another method which can increase compliance of Deficiencies. The other thing, of course, is the harder thing of increasing compliance of desferrioxamine is a much more difficult thing. You have to actually explain why it is important, and you will find that in clinics very often we spend time and time again to the same patient, maybe every 3 months or 6 months, explaining the progress, kind of the carrot and the stick approach. There's no real stick. There is a carrot sometimes, rewarding people who get very good ferritins. On the other hand, not really reprimands, but sometimes really showing them the negative side of a bad iron. Like, for example, very recently when the last patient died of heart failure, the compliance to chelation improved in the unit. And so that was the stick, which was not what we wanted to happen, but fear sometimes drive them to increasing compliance. So these are practical things. I don't think I need to spell out everything. But when you are dealing with, the issue here is that the drugs we have are not very efficient. The 3 chelators we have are, if they were very efficient drugs, if they were able to remove the iron, just like, I don't know what, an antibiotic kills a germ, or you drink 3 glasses of bottles of water and you run to the washroom to pee, you just get rid of that as easily as that. unfortunately, the chelators are not very efficient. They are not able to deal with very high levels of iron which are stored. They only get rid of non-transferring bound iron. And once that is out, only they remove the stored iron. So it's a very, very slow process. So we have to deal with what we have. So that is the problem. So, you need a lot of persuasion. It's a hard thing. If I knew the answer, easy answers to that, maybe I could publish a book.
And sir, this is another practical problem. Now, how to increase iron chelation in patients who have good compliance and on maximum dose of iron chelators, but they still have a high serum ferritin level. At Anuradhapura, I see a lot of patients like this whose compliance is very good and they're on maximum dose, but still their serum ferritin is not under control.
Again, it's hard to answer that, Dr. Sonali. Really don't know what's happening there.
I just came recently to the thalassemia, and so those are the practical problems that I'm faced with.
Yeah. So if you really go through the case records and individuals, and you will come across individuals like that, I think you have to tackle one individual at a time and look at the individual issues. I don't think there's one recipe to answer all these questions. There are many factors, whether the drug actually works and whether the compliance is actually as genuine as they say it is, and whether they take the drug at the right time and all that. It's most of the time, just like your diabetic patient who vouchers for good compliance, but your HbA1c is going up and up and up, you always find a crack in the story. So it's I honestly I don't know the answer to your question, but you should probably look harder as to what exactly is happening. But what I can say is that if it is genuine, you have to work with the resources you have. Like, the drug you have, a drug which is often not the original product. You really don't know the quality of it, but you should never give up based on the suspicion that it doesn't work, but use it to the maximum possibility. Sometimes even you that would help, and that is something which again we have been doing. Deferasirox supratherapeutic doses have been used time and time again when the drug doses haven't achieved the
I can't hear you, Prof. Sanuja. Can you all hear? I can't hear you, Prof. Sanuja. Can the others hear me? Can the others hear me?
Yes, Dr. Sonali, we can hear you, but we have to wait. I think some problem with sir's internet connection.
I think we lost Anuja for a minute.
Yes.
Let me check.
Sorry, I'm back.
All right, okay.
So the next question is how to the iron chelation patients who are allergic to desferrioxamine. There's one patient who is allergic to desferrioxamine and she is on Deficiencies. So at the moment her iron is just above 1000. So what to do with the patients who are allergic to desferrioxamine? She says she gets a rash and chest pain when she takes subcutaneous desferrioxamine. I can't hear Professor Anuja. Can others hear me? Can others hear me?
We can hear you, Sonali.
Yeah, there's again problem with Professor Anuja's computer, I think.
Was there another question, Sonali?
Yes, iron chelation in patients who are allergic to desferrioxamine. One patient who is allergic, she complains of a chest pain and itching of the body when she takes desferrioxamine. At the moment, she is on Deficiencies. And fortunately, her iron level is not very high. It's around something between 1000 and 2000.
My connection is terrible here. Are you asking about the allergy question or the volume question?
Yes, allergic. For question number 4.
Oh. Iron chelation in allergy dysphagia. That's again a difficult question to answer because first you have to find out whether it is a true allergy, because what patients define as an allergy may not actually be an allergy. It might be a poor technique. You know, even patients who have been using the drug for a very long time may be not doing it right this time. So what we would often do is to get them down with their own machine and ask them to demonstrate actually what is happening and cross-check with them about what's happening. And then you have to, you know, this is talking about the subjective issues. And patients have concepts, their own theories about drugs. I'm sure you would have come across this. The ratu behetai, kola behetai. You know, when a drug changes from one brand to the other, they would not want to use the other one. And in that case, they might start talking about allergy to a certain drug and they insist that they get, you know, for example, they would want the Novartis brand and they would not want the other brand. And so be a bit wary about these issues before you actually label them as a true allergy. But then, of course, that is not to say that there are no true allergies. But if it is a genuine allergy, of course, you are stuck for choice unless you'll have to give up on the drug. I don't think we have, of course, tried with giving with hydrocortisone and giving with, Piriton and all that. Sometimes it works, sometimes it doesn't. And after a while, we have tried to reintroduce. It works in some, it doesn't work in others. But you have to remember that it could be a batch problem. Sometimes with one batch of desferrioxamine, it has a problem, and the next batch, because it may not actually be the drug, it might be the additives which are used in the drug which is causing the allergy. So you could, just because the patient says you are allergic to the drug, don't give it up. But what we would do is we'll try it in the unit rather than asking them to try it at home, because then, of course, you will be found negligent.
My last question to you, sir. How to decide on the volume of blood in a patient with heart failure?
Very, very tricky. We actually had to deal with this just last few days. The scenario where the patient did not survive. You know, this happens when the patient is anemic and having heart failure as well. You know, it's you need obviously the patient will have to be managed in the setting of a high dependency intensive care unit. The volume management will be essentially with the help of a CVP. So it is there's no easy answer. You know, it is the only things which should be going in has to be very carefully monitored. So desferrioxamine has to be going in, and it has to be a continuous infusion and with the lowest possible volume, and the rest has to be preserved for blood. And blood, of course, you know that you can't be giving it non-stop. You have to finish it off within about maybe 3 hours maximum. And again, the amount you give will depend on how anemic the patient is. And so you don't have to really push to make the patient 13 grams when a scenario you are in profound heart failure. I think here you need clinical judgment. I think it is hard to say this system, there's no formula for this. So you essentially based on CVP.
Thank you very much, Professor Anuja. You have solved a lot of more of my practical problems. And thank you, Professor Sandit. And I thank the College of Hematologists for giving this opportunity. And thank you very much all who joined this workshop. Thank you very much.
Thank you, Sonali. Last but not least, let me introduce Professor Anja Premavardhana, Senior Professor in Medicine from the Faculty of Medicine, University of Kelaniya. Over to you, Anuja.
Do you want me to do the alpha thing, Senani?
Yes, Anuja.
Isn't it too late? People have left. Most of the people have gone to sleep, I think.
There are quite a few, 50 or
You
50
want?
plus.
Okay. If you insist.
Yes, please.
Give me a second. Can you see?
Yes, Anuja, we can.
Full screen?
Yes.
Right. I just rushed through and, let everybody go to sleep. So alpha thalassemia, you're talking about the alpha genes, in chromosome 16, you have alpha 1 and alpha 2 genes together with the theta and the pseudo alpha 1, pseudo alpha 2 and the zeta gene. And when you're talking of alpha thalassemia, you all know that you have 4 alpha. Normal people have 4 alpha genes, 2 from the mother, 2 from the father. So you can lose all 4 alpha genes. You end up with Bart's hydroxyfetalis. You lose 3, you end up with HBH disease. And alpha thalassemia trait is B, C, or D. If you lose just 1, you have alpha trait. If you lose 2, it could be in 2 forms. You can lose in 2 chromosomes, or you can lose in the same chromosome. If you lose in the same chromosome, you call it alpha 0 thalassemia. But all 3 of them are classed as alpha thalassemia trait. Now, there are over 100 genetic forms of alpha thalassemia identified, and the clinical variability could vary from extremely mild to lethal forms. And the severity would depend on the number of non-functional alpha genes. And essentially, as I mentioned, it is either considered alpha plus or alpha 0, which used to be alpha 1 and alpha 2. Alpha 0, the more severe form, used to be called alpha 1. And the milder form used to be called alpha 2. So the severe form is due to deletion or double deletions, as I told you before. Alpha plus thalassemia could be due to loss of one gene or due to a non-deletional alpha thalassemia, as shown in this slide. So severe alpha thalassemia essentially is due to alpha 0 thalassemia. And this map shows you the global distribution of alpha thalassemia. And as you can see, this shows you in light color alpha plus thalassemia and in the dark color alpha 0 thalassemia. The most important thing to see here is that alpha 0 thalassemia, the most severe form, is a huge problem in Southeast Asia and to some extent in the Mediterranean. It's not found anywhere else. Whereas alpha plus thalassemia, or the milder form, is a much huge problem. Not what I mean, not huge. It's numerically a big problem in the same region where beta thalassemia is, all over the thalassemia belt. And the other important thing is to look at the numbers. Look at the number of alpha thalassemia trait, the milder forms. In some regions of India, 80%. In some regions of Middle East, 60%. And in areas of Africa, reaching 40%. So alpha plus thalassemia, the milder forms, are found in a massive number of people. It's not working. Now, this shows you the kind of gene deletions. Now, the other important thing to remember is that beta thalassemia is usually due to a point mutation, very often due to a point mutation, and is rarely due to deletions. Alpha thalassemia is the other way. It's mostly due to deletions and rarely due to mutations. Now, this shows you the kind of deletional alpha thalassemias you can get, which cause alpha plus thalassemia. And again, a lot of them, but there are two of them which dominate, though there are quite a lot in this diagram, and there are two of them which dominate. This is called the 3.7 deletion and the 4.2 deletion. Now, this is the same thing that we showed before. Here you see the prevalence of the 3 deletions or HBH disease in the world. And as you can see, it's a lot of that in Southeast Asia, including in China. And you can see quite a lot of that in the USA as well. This is again due to the migration of mainly Southeast Asians to this part of the world. And Bart's hydrops fetalis again is a major problem in Southeast Asian region and to some extent in the United States because of the migration of Vietnamese people and the others to that region. Now, alpha carrier state, loss of one gene, is it a problem? Well, the problem is actually due to the very mild hypochromic microcytosis it causes. It can often be misdiagnosed as iron deficiency. Otherwise, it hardly ever causes any clinical disease. And on the other hand, if you lose 2 genes, it often causes a substantial reduction of MCV and MCH, and it will cause some degree of anemia. So single gene deletions is 3.7 deletion, which is the commonest thing which you will find in Sri Lanka. The clinical problem it causes is the misdiagnosis as iron deficiency. Now, severe alpha thalassemia, the most severe form is, is Bart's hydrops fetalis. Bart's after St. Bartholomew's Hospital. And Bart's hydrops fetalis is to loss of all 4 genes, which is lethal soon after birth. And affected embryos succumb to severe hypoxia, either early in utero or late. So it depends on either depends on the kind of deletions. For example, the Filipino deletions, you will die early in utero, whereas if you have what is called the Southeast Asian deletion, death usually will happen in the 3rd trimester. You see, now, when you have no alpha genes, what would happen is that the gamma genes would bind together, and that is what is called HB baths. So the 4 gammas together is called baths. The other type of hemoglobin they would have in the baths fetus is HB Portland 1, where you have zeta 2 and gamma 2. Now, the problem with this baths fetus is that these hemoglobins, the baths hemoglobin and Portland hemoglobin, are extremely high affinity hemoglobin. They are as 10 times as high affinity as HbA, and because of this, they cause extreme tissue hypoxia. Because of this very high tissue hypoxia, the fetus ends up with cardiac failure. And from this cardiac failure, there is capillary leak, and that is why the fetus engorges and enlarges. And the fetal heart, which secretes because of under extreme stress, it starts secreting vascular endothelial factor, and that is what causes damage to the placenta, and which exudes back to the mother and causes maternal complications. So having a Bart's baby not only causes death to the fetus, but it will cause significant amount of maternal complications. Now, there are few Bart's children alive now, and this is because of the development of intrauterine therapy. If you start intrauterine, if you diagnose it early on, if you identify that the parents have the deletion, and you diagnose the child in utero, if you start intrauterine transfusions, you can keep the child alive. However, these children very often have lots of problems after birth. They have growth retardation, neurodevelopmental delay, and a lot of congenital abnormalities. So even though you can keep them alive, this is very unlike thalassemia major children, because they are very likely to be prone to many developmental problems. Now, the other side of having a Bart's fetus in utero is the maternal complications. And there's a lot of preterm delivery, and the mother is likely to develop complications like polyhydramnios, oligohydramnios, and the other stuff. And congenital abnormalities are very common in Bart's hydrops fetalis. And the commonest abnormalities they have described are related to the urogenital system in these babies. Now, moving to the next severe form is hemoglobin H disease. Now, this is again very interesting, because there are two clinical subtypes, the deletional HbH and the non-deletional HbH. These are very, very different. The deletional HbH disease is often a mild disorder, but even though you call it mild, there's again, just like in E-beta thalassemia, there's very wide phenotypic variability. Now, unlike in thalassemia, beta thalassemia, the main cause of anemia in HbH disease is not ineffective erythropoiesis, but hemolysis. And this is due to the precipitation of the 4 beta chains. And as I mentioned before, there's extreme phenotypic variability, but the most extreme phenotypic variability in HbH disease as a group is because of the non-deletional type. The deletional type in general is mild, but the non-deletional HbH very often becomes more severe than the deletional variety. Now, when you talk of the non-deletional HbH, there are 2 types which are common globally. this is the constant spring, and HB Paxe. And these patients with this non-deletional HBH are associated with much more severe anemia that's more likely to have splenomegaly and higher rates of iron loading, much more likely to develop severe infections, leg ulcers, gallstones, end up with splenectomy, which is not very common in the deletional form of HBH disease. And then on the other extreme types of severe HBH disease is also known due to non-deletional HBH, like HB Paknum Po, and very oriental names like Huangzi and HB Adana. These are so severe that these are almost transfusion dependent. So recap, HBH disease, there's extreme phenotypic variability. The deletional HBH is severe than non-deletional types. Now, alpha genes in general tend to work as genetic modifiers. If you have alpha thalassemia, for example, coexisting with beta thalassemia, it ameliorates the disease severity of beta thalassemia. Now, this is very well shown. If you have E beta thalassemia, if you have co-inherited alpha thalassemia, you end up with a milder phenotype. And this is, for example, in population studies like for example, in Kurunegala, there are very few E beta thalassemias with alpha thalassemia. The reason is that it's probably so mild that they don't even come to hospital. And then there's this very curious thing, which is very interesting. There's something called epistatic interactions. Now, the reason why thalassemia mutations have occurred in a population is very well known, that they have occurred as a protection against falciparum malaria. Strangely, if you have one strong protector, you don't want to have another strong protector with you. Now, for example, if you have sickle mutation, which is an extremely strong protector against malaria, if you also have alpha thalassemia, which is also a very strong protector for malaria, your protection against malaria goes down, not goes up. This is called an epistatic interaction. So, co-inheriting alpha in the presence of sickle is not beneficial. It is actually loses the benefit of having the other mutation. This is called an epistatic interaction. The negative side of alpha is if you have more alpha genes. Just like you can lose genes, you can sometimes gain genes. Now, there are individuals with thalassemia intermedia, beta thalassemia intermedia, who have beta thalassemia trait, but who have co-inherited not 4, but 5, 6, 7, or 8 alpha genes. So if you inherit beta trait, an excessive number of alpha genes, your phenotype will be worse. Now, this happens for a very simple, explanation due to unequal crossover at meiosis. So you end up on one chromosome with alpha thalassemia, you lose one gene. On the other chromosome, you gain the other 2 genes. So this chromosome has ended up with 4, whereas this one has ended up with just 1. Single gene here, this is alpha thalassemia. This guy has ended up with 3 alpha genes. Now, the final part of this, alpha thalassemia in Sri Lanka. What do we know about this? Now, I'm sure all of you are aware that alpha thalassemia is far more common than beta thalassemia in Sri Lanka. Beta thalassemia prevalence is 2.5%. Alpha thalassemia prevalence is almost 10%. It's more common amongst Moors or Muslims than amongst the other 2 races. And the the district-wide prevalence follows the same pattern of beta thalassemia and E trait. It's more common in Anuradhapura, Kurunegala, and the eastern provinces. Alpha-0 thalassemia has also been reported in Sri Lanka. The first case was reported way back in 1964, and a family case report was described in this case report, I think in the CMJ, in 1988. But the molecular characterization of this alpha-0 thalassemia in Sri Lanka was first done in 2013 by very elegant clinical work done by Sashikala Suresh, one of your own, where she basically collected information of individuals with severe anemia or moderate anemia rather, who had hypochromic microcytosis, not responding to iron, or who did not have iron deficiency, nor did they have beta thalassemia. And with this, there was these 3 families which ended up being studied in detail. Some of them had HBH inclusions. And there was, and interestingly, all 3 of the families were Muslims. And this led to the diagnosis of the Sri Lankan deletion in this family. And in this same publication, described the existence of non-deletional thalassemia, alpha thalassemia, also in Sri Lanka. 3 non-deletional mutations were also described: HB Evanston, Poyadora, and this IVS1 1117 G2A mutation. And these, the coexistence of these non-deletional mutations in the homozygous state produced severe anemia with HBH inclusions. And this was the publication. And this was characterized. And the last story is of the occurrence of alpha thalassemia without having a deletion or mutation of the alpha gene, which is called the ATRX, or alpha thalassemia associated with mental retardation, which is an X-linked syndrome, where a defect in a regulatory protein, regulatory gene, causes multiple phenotypic abnormalities. In addition to that, they end up having alpha thalassemia, where alpha thalassemia is only a manifestation where the alpha genes are unaffected. I think that's it. Thank you.
Thank you very much, Anuja. Any questions? I know it is very late.
I hope not.
That is a very clear presentation, Anuja. Thank you very much. On behalf of the Sri Lanka College of Hematologists, let me thank Professor Anuja Premawardana, Professor Sachit Methananda, our 4 panelists, Sevandi Basnayaka, Sonali Gunathiraka, Thanuji Somaratna, and Swarna, for very clear presentations on your work in the peripheries, and my co-host, Dr. Dhammika Gunawardana, who started the ball rolling with coordination while I was away, and Anova, who has been behind the scenes, and also the 2 secretaries, Halda and Hirosha, for all the hard work. And on behalf of the College of Hematology, a big thank you for all those who have joined online, and a million apologies for the bad connections with the power failures, and for putting up with the power failures and numerous interruptions. Thank you again for joining us, and we will keep you informed with the future topics that we'll be doing, similar topics in the future. Thank you again, and good night.